It's
Sure. Mhm.
some key people text us that they will be late, but I think we better start and then we can follow up with some part missing through the recorded video instead. Can you hear me?
Yep.
Yeah. So, yeah, we look forward to your talk today, Prof, regarding this how to manage difficult stoma. It will be complementing nicely with the talk and the workshop that will be shared to the big group this November. Thank you, Prof.
Can you see my presentation?
Yes, yes.
Okay, great. So my name is Kim Liu. I'm a colorectal surgeon from OHSU. I'm a professor of surgery, actually, as of last year. Thanks to the chance to give me international talks to Thailand. So thank you very much. And thanks for giving me that talk about ostomies. So I don't have any relevant financial disclosures. These are the primary references. I sent a copy of this to Nikki so she can share that with you. But the American Society of Colorectal Surgeons has a bunch of clinical practice guidelines for when to operate on ostomies. And then also, a lot of this is experiential wisdom shared to me by the ostomy nurses. So generally speaking, whatever they tell me is pretty much right. So a wise surgeon once told me that good surgical judgment comes from having a lot of experience. A lot of experience comes from making really bad, poor decisions. So I've had a lot of experience, which I'm happy to share with you. So ostomies. Ostomies are when we sew the bowel to the abdominal wall for various reasons. For example, for ileostomy, we sew the small bowel to the abdominal wall, and a common reason for that would be someone with an obstructing rectal cancer, that we need to relieve the obstruction before they can get their radiation or chemotherapy. Ostomies can be either an end where there's just a single lumen sewn to the skin, or it could be where we cut it in half, so 2 lumens to the skin, so it's called a loop. Same thing for colostomies. Colostomies are just basically the colon sewn to the skin. And this is an example of an end colostomy sewn from the descending colon. So, for example, someone who had obstructing sigmoid cancer may have resection of the sigmoid colon and an ostomy sewn to the skin. So what's normal function? When you have an ileostomy, which is small bowel, we tend to have higher output because small bowel absorbs nutrients, but the colon absorbs water. So if you have small bowel output, a lot of water will be lost. So patients typically will empty their appliances 4 to 6 times a day, and they change their appliances roughly every 3 days or twice a week. For a colostomy, it's because it absorbs water, there's a lot less output from a colostomy, so it's a little bit simpler to take care of. We empty the appliance maybe once, 3 times a day instead of 4 to 6 times a day. And we might actually change the appliance just once a week. So ostomy appliances, this is kind of what they look like. These are cartoon pictures. This is actually the back of one. So after I make an ostomy, I'll actually peel off this plastic portion, cut off the right size, stick that to the down wall. And the bottom portion, you can open up with Velcro, kind of like my children's shoes. So my kids don't tie their shoes anymore. They just Velcro everything. There's also a 2-piece appliance where you attach just to the down wall, and this gets attached to the wafer. This is another picture of a 2-piece where the wafer is attached to the patient, and then this is attached to the wafer. To make things stick better, sometimes we use something called an Ekin ring. It's basically the colostomy or ileostomy version of caulk. So you know how you use caulk in your bathroom or your kitchen to make sure it's watertight and doesn't leak. We use this to place it around the ostomy, and then the appliance will just stick to this. So it makes a little bit of a tighter fit. And then for some people, you can actually attach a belt that attaches to one portion of the appliance, goes around the abdomen, and then gets attached to the other side. This is really helpful, typically for actually our bigger patients, to help it really stick on to the patient so it's less likely to fall off and leak. So the key to having a well-functioning ostomy is actually our partnership with Ostomy therapy. So these are nurses who've actually done additional training in both wound care and taking care of ostomies. And we actually have a cadre of about 2 to 4 nurses, of which one of them, Sarah Dutch, is actually going to be visiting Thailand with Dr. Sikidis and I in October. So you'll get a chance to meet her with her workshop. But we typically would have a patient meet like Sarah, learn what ostomy is, what do the appliances look like, and then get marked in an appropriate location for us to place an ostomy. But they're not just pre-op. These nurses actually will teach patients how to take care of it post-op. And so in the hospital, the nurses will show them how to change the appliance, empty appliance, troubleshoot the appliance, and then they'll let the patient do it while she washes. And then once she's comfortable that the patient knows how to take care of it, then they can go home. So my talk is actually on non-well-functioning ostomies. So what are different ways they get a problem? Well, an ostomy puts out stool, and if the appliance doesn't fit quite right or doesn't stick on, it could be very, very messy. You literally spill stool everywhere, over your clothes, at work, and this is super embarrassing and messy. You can also develop hernia. We'll talk about this because we have to make a defect in the down wall to bring the ostomy through. That by definition, making a hernia, but it could actually be a problematic hernia, which we'll talk about. And the ostomy can actually be too tight, be too small, or it can be putting out too much so they get dehydrated. So we'll address each of these one at a time. And if you have any questions, feel free to raise your hand or ask questions. I'll be happy to stop and answer your questions. So the first one is difficult with pouching. So, for example, say a patient's been obstructed with a rectal cancer, and you bring up an ileostomy or colostomy, it's very dilated. You have to make a really big hole in the downward wall, and you have really swollen intestines that you sew to the downward wall. So it makes it really big and hard to keep a pouch that's big enough to get around it. So we actually have our ostomy nurses actually troubleshoot a lot of it in the hospital. And they actually can see the patients, they have their own separate clinic to help us sort out problems. But then a lot of times it's due to a problem where they have a hernia, where the defect's so big, the small bowel or large bowel hernia goes through the fascial defect and can lead to a big problem. So how can we diagnose this? So a wise hernia surgeon once told me that of all the hernias that you could repair, that the abdominal wall reconstruction people look at, the one that is the hardest for them to manage is a peristomal hernia. So one guy was a little bit fatalistic, and Samuel Beckett said, try again to fix the hernia, then you fail again, and then the third time you fail better. W.C. Fields, he's a very old comedian from the U.S. Who used to drink a lot, actually. And he had a quote where he didn't actually fix peristomal hernias, but he commented on a similar problem where he said, if at first you don't succeed, try again, and then you quit, because there's no point in being a damn fool. So hernias can actually be diagnosed clinically. Like over here, you can see this is where the appliance is stuck to the patient, and there's this big bulge around it. That's one way of doing it. The other way you can see is you can see it telescoping out or prolapsing out. That's pretty characteristic of a hernia. And to be honest, if you have a hernia, make an ostomy, at least 50% of them will develop hernias, depending on how far out you follow them. So you can actually diagnose it by CAT scan. Some of our patients in the US are a little bit big, and the abdominal wall is so thick it's hard to evaluate them. So you can actually see right here is the fascial defect. So this right here is the colon going through, and this is actually additional bowel that's going through this hernia defect. So how do you fix a hernia associated to an ostomy? Well, one good way to get rid of it is actually just to get rid of the ostomy. So say it's a temporary ostomy where you remove your rectal cancer, you do your colorectal anastomosis, you make a diverting ileostomy, you wait a few months to let it heal, and then you can get rid of it. That's one way of managing it. But then what if you can't get rid of the ostomy? What if it's a permanent ostomy? It's a big rectal cancer involving the anus. You cut out the rectum, the anal sphincter, and you bring up a permanent colostomy, and you can't take down the ostomy. Well, a traditional way of doing it is, well, if the idea is that the fascial defect is too big, well, let's just make the fascial defect smaller, put in a few stitches, make it tighter. And what we notice, especially if it's a recurrent peristomal hernia, if you just use stitches, the risk of it coming back is over 100%. So it's just an act of futility. So some people say, well, that part of the down wall is just bad, so let's move it somewhere else, make a fresh ostomy. Now, if you recall, any ostomy that you make has 50% chance of having a hernia. So what happens is you remove it from one part of the abdominal wall, you move it to a new part of the abdominal wall, and that new part of the abdominal wall has a 50% chance of developing hernia. And the old one has a 24% chance of developing hernia. So this doesn't work that great. And we've known this for decades. So is there a better way to address how to fix hernias? And one way to do it is to use mesh. So mesh is permanent. We typically use a macroporous or a lot of big holes in the mesh prosthetic, so polypropylene or Prolene. So macroporous, lightweight polypropylene. And we actually do like a midline laparotomy away from the ostomy, get in the space behind the rectus, place the mesh there, and then close. And this, you can actually do it where you make one piece of mesh, cut a circle in it, in the slit, and then you just sew the slit shut. Or you can have two pieces that are U-shaped that you put together, and then you sew them together. This is what we call the keyhole version. And then another one is, this is my favorite. This is easy to do laparoscopically, where it's called a modified sugar baker. Sugar baker is an older surgeon. And basically, the idea is, this is a traditional over here colostomy, where you make a hole, the colon goes straight through. What the sugar baker does is, the bowel starts laterally, and then goes medially, and then goes through the down wall, and then you put mesh, basically lift it up, kind of like a hammock, kind of holding the colon there. And the idea is that when you have increased abdominal pressure, So you're lifting or you're bearing down, that would push this way, and the mesh will hold the colon against the wall versus just telescoping through. And this actually has a pretty good success rate, where we talked about like 24, 50% recurrence rates. This is on the order of like 10%. So this is actually a pretty good repair. But as you know, things can recur. So this is kind of like the nuclear option, where we have actually general surgeons who spend an extra 2 or 3 years of additional training to do abdominal wall reconstruction, where their whole specialty is fixing hernias. And Eric Pauli I believe, is at Penn State, and he developed this procedure in 2016 where he does abdominal wall reconstruction, where he plates mesh in the retrorectus space. And I'll show you a picture of this in a second. Right, so right here, so in this whole retrorectus space, so here's a rectus on both sides. You have a mesh that basically reconstructs the whole abdominal wall, and then the colon goes in laterally, just across medially, and then goes through the abdominal wall. Kind of like the sugar baker we talked about, except in this case, the colon's actually going through the retrorectus space. And this is kind of a very elegant thing that I actually don't do, that but my abdominal wall reconstruction colleagues do. And it's actually a really nice repair. It can be done open, it can be done laparoscopic, it can be done robotic, depending on your training. So, but the thing is, in addition to hernias where, say, the fascial defect's too wide, so if there's a big peristomal bulge or it prolapses out, you get the opposite problem where the ostomy is too small. And that's a problem because it literally leads to an obstruction. So why would that happen? So in the US, we tend to specialize in having fat patients. So what happens is if you don't mobilize the colon enough and you pull it through the abdominal wall and there's tension, it could retract or recede. And then the skin and subcutaneous tissue above the ostomy will scar down. It could lead to a stenosis. So one way to fix that problem is to get rid of the ostomy if you can. But if you can't get rid of the ostomy, what you do is you cut out the scar, you mobilize the colon completely. So you cut out the scar above the ostomy, you mobilize the colon completely around, away from the abdominal wall, you mobilize and pull it up, and then you remature it. So it looks like this instead of like that. That's one way of managing it. But you can also get a stenosis at a deeper level. Like, for example, when you do the original surgery, you want to have at least 2 or 3 fingers that can go through the fascial defect. Excuse me. And if it's too tight, what will happen is the bowel contents will get stuck right here, like a obstruction. And that's actually pretty easy to fix. At the bedside, you can put your finger into the lumen, and if you can get your finger into the intra-abdominal colon, you're probably okay. But typically, what you'll find is that it's really tight. So you put them to sleep, you free up one edge of the colon away from the abdominal wall. You place your finger right here, and you cut the fascia onto your finger so you can get your finger back into this intraluminal colon, and then you remature it. And that's actually a pretty easy fix. It's better to avoid the problem in the first place by making sure that you can get your finger in the colon before you wake up the patient. But one of my biggest problems actually is something that's reflected in our recent quality adjusted outcomes, which is high output ileostomies leading to dehydration. Now, we typically want after our patients are being taught how to manage their ostomy, it's working fine, they're eating a regular diet, they feel comfortable taking care of it. But sometimes it's just putting out too much. And there's various ways of managing that. But we want them to have at least less than 1,200 in 24 hours. So there are a ton of medical options, which our GI colleagues are probably really good at managing. I mean, one way of managing high output is to drink fluids to compensate. So you can drink 1.5 to 2 liters a day. You want to avoid hypertonic solutions like soda, because that can lead to dehydration. If you use psyllium or metamucil or any sort of fiber, about 12 grams a day to try to thicken the output. There are anti-motility agents like Imodium or Lamodal or diphenoxylate atropine, which are basically each about 2 tablets 4 times a day. I actually had a patient that had such high output that actually ran out of opium in the whole state. So we couldn't give it anymore. Some people believe that gastric secretions may contribute to high output ileostomies. So they use lansoprazole to try to decrease gastric secretions. But some patients that are so severe, you actually have to tell them not to eat anything by mouth and give them TPN until their time is you can actually take down the ileostomy. I've actually included a reference and emailed that to Nikki about the medical management of ileostomies. So what's really clever is there are nursing options to help manage these patients. So in 2012, Beth Israel Deaconess, which is one of the Harvard hospitals in Boston, has a special place in my heart because I did my general surgery training as a medical student there. And basically, the inpatient nurses, outpatient nurses, and ostomal therapists got together and created this pathway. In this pathway, the pre-op nurses, some of the nurses mark the patient, they teach the patient. And they have standardized teaching materials that they give to every surgery patients. And then they do inpatient in hospital teaching by endosomal nurses. And they're taught to keep track of how much output is coming out of their ostomy. And if it's more than 1,200 in a day, they call the nurses that day and they can titrate up Metamucil or Imodium or diphenoxylate atropine to get them to have a lower output. And they actually will see the ostomy nurse and the colorectal surgeon within 7 to 10 days after discharge. So this is actually a pretty nice pathway. And the funny thing is, if you actually read the reference, the nurses agreed with it, the endosomal therapists agreed with it, the patients agreed with it. The only people who didn't really participate was the surgeons. Because the surgeons are kind of finicky bunch and they only want to do things their way. So despite the surgeons not really cooperating, what they've done is they track their outcomes and they found that when nurses track the patient's ins and outs, so the output from their ileostomies, and they adjust their medical therapy or like their Imodium or their fiber, their Imodium or their Lamodal to lower their output, they decreased their 30-day readmission rate for dehydration from 16% to about 4%. So that's quite a dramatic drop just from a nursing protocol. And this is where it's really nice to have a team approach to taking care of patients. Because it's one thing for the surgeons to operate on, but it's another thing to optimize pre, intra, and post-op care. There are actually a lot of other awful things like necrosis and pyoderm gangrenosum that I'd be happy to talk about. But I think, let's see, how do I stop sharing? Stop there, stop sharing there. Actually, this went a lot faster than I thought. That's all I have. Do you guys have any questions about this?
Thank you, Prof. um, Doctor, I start from BHQ. Anyone have a question? Dr. Wood or Dr. Kun Kai?
Hello, good morning. Okay, can I ask you something? The problem about the parostomal hernia, I think my problem is just when it recurrent. What is your choice after like a week fix you? But he the patient is like got the revise from the other hospital, but the surgeon did not push the mesh, but it recurrence again. It like the hernia happen again. What your suggestion to do in case of just say recurrent?
So a couple of things. One is if you wait long enough, almost every ostomy will or hernia will recur. So I would operate on only symptoms. So specifically, if they can't keep a pouch on their appliance to their abdominal wall, like for a colostomy, say if you can't keep it for more, three days or longer, then we consider it. Though a lot of times our endostomal nurses can actually find appliances like a convex or a concave or one that uses Eakins rings or uses a belt so you can avoid it. Because the thing is, these are the hardest hernias to fix. And then the other thing was, a lot of these hernias, the ones with the highest recurrent rates are the loop colostomies or the loop ileostomies, and a lot of those are temporary. So if you can get rid of your ostomy, it's actually the best option. But we're actually lucky because we have general surgeons who specialize in hernia repairs, and they are happy to fix it, especially if they're having obstructive symptoms uh, or they're having significant prolapse and they can't keep an appliance. But they generally uh, will do it one of two ways. If you can get rid of the ostomy appliance, sorry, the ostomy, they'll have me get rid of the ostomy and then do a temporary repair. Like, for example, like bridging alloderm or some sort of bridging or even primary repair. And then they'll come back and do a formal reconstruction. Or if they can't do that, then they'll probably do that Pauli procedure that I was talking about, where you do a full abdominal reconstruction and then you tunnel the colostomy through. But generally, recurrent hernias will involve some sort of mesh, and prosthetic mesh is totally safe.
Thank you. The other question, if in case of just like advanced cancer and stage 4 cancer or something that spreading in the tummy, and the patient needs colostomy, sigmoid colostomy or transverse colostomy that you like prefer more, and like you think if there are less incident of parostomal hernia.
So I think they both the sigmoid and transverse will have similar rates. Like I said, that loop colostomy is the highest risk of hernia. So I would say I try to do a sigmoid colostomy because a lot of these patients have rectal cancer. So I'll resect the colostomy with the rectum and do my reconstruction. It makes things a lot simpler. The other thing was transverse colostomies are difficult to manage because the transverse colon tends to be a little bit bigger than the sigmoid. So you tend to have a bigger fascial defect. So those tend to be bigger ostomies. You tend to have higher risk for hernia. They tend to be a little bit higher output because you're bypassing a fair bit of the colon. But, for example, say you have a descending colon cancer, the only way you have to have a colostomy proximal to that. So distal, transverse might be what you have to do. Though a lot of times I'll actually do an ileostomy because those are the easiest to get through the abdominal wall, and those will reach anywhere.
Thank you. Yeah.
I'm afraid it's not very sexy talk, so I apologize for that.
No worry. Kun Tharani, any question regarding the ostomy for Prof. Lu?
No ค่ะ thank you ค่ะ
Okay. Group 2, Dr. Vinita or Dr. Pitulak, anything from you? Hello?
She might be scoping.
Kun Kanya as well. Any question?
Nothing ค่ะ
Please note that there will be a ostomy workshop by Sarah Duscher in early November. We haven't blast out this thing
Yes.
yet, okay?
Yes, please.
have
Yes,
some-
please.
Dr. Kim,
Uh,
hello. Do you hear me? Sorry, I'm in my case. You hear me?
Yeah. It's good to
Okay,
hear you.
hello.
Hi.
Sorry, I have like the kids this morning. So from the GI part, we do not deal with ostomy consequent that much, but the things that we deal with is like the bleeding around ostomy wound. Do you have any suggestions on that point? Like the bleeding from granulations or
Yeah, so if it's superficial, a lot of times what will happen is the ostomy will prolapse out and then rub against the appliance and then develop like granulation tissue or an ulcer, and that can be treated with silver nitrate. The other thing is I've actually had patients with cirrhosis develop peristomal varices, and it's actually an easy thing to take care of. So what we find is that if you disconnect the ostomy from the abdominal wall, resect the end and reconnect it, you'll at the mere dissection where you separate from the wall would oversew all the varices. And a lot of times that's like a simple 20-minute case that can help with at least peristomal bleeding. And then I know IBD is less common in Thailand, But for us, we also tend to see a lot of peristomal skin ulceration. It's not necessarily because the appliance doesn't fit, but it's because of pyoderma gangrenosum, which is where the autoimmune attack against the colon actually hits collateral skin nearby and can be treated just like IBD, where they use biologics. Or you can just get rid of the ostomy, because yeah, it's the ostomy that's causing all the problems.
Thank you. I recently have one case that she have like rectal cancer like 10 years ago, and she doing like colostomy. And she came in with lower GI bleeding, which been proved is caused by Escherichia colitis on the left side. And she have really big intestinal hernia at parathermal hernia. Do you facing the case like this before? I mean, like, is there anything to do with hernia and Escherichia colitis?
So I operate with the abdominal wall or hernia surgeons. It's a lot. So for the ischemia, a lot of times we resect that colon, and then if this healthy rectum will take down the colostomy and let this hernia surgeons reconstruct the entire abdominal wall. It's easier for them to fix the hernia, because a lot of times the first operation was a big midline incision, and then they have a hernia there, and they have a hernia also on the ostomy. So if you can get rid of the ostomy, it makes it then they can actually reconstruct the wall with mesh, and it's quite elegant. Well, at least their portion's quite elegant. Mine is just simple plumbing.
Okay, thank you.
Thank you, Dr. Vinita, for your spirit joining from the
I'm
scope.
still doing colonoscopy, but I can do it.
Okay. Okay. Dr. Pitulak, any question from you?
Yeah, the same as Dr. Vinita. We are gastroenterologists, so we don't have a lot to do with the ileostomy, the colostomy. Thank you.
Okay. Note ค่ะ thanks. How about Rosalind พัทยาคะ Hello พัทยา Okay. Let me. I couldn't hear you, but never mind. I can move forward. Dr. ต้นคะ
Yes, thank you. I'm colorectal surgeon. Because of the difference of the common complication between ileostomy and colostomy, included different technique of the crusher ostomy. Then in the case of surgery of rectal cancer, do you prefer protective ileostomy or colostomy? And if colostomy, you prefer right transverse or left transverse colostomy? Yes.
So I would say if it's an obstructing rectal cancer, a lot of times I look at the CAT scan and see if the small bowel is dilated, because if the small bowel is dilated, that suggests that the ileocecal valve is incompetent, and then ileostomy is what I prefer, because my next operation will be a low anterior resection, coloanal anastomosis, and that way I don't have any ostomies that get in the way of my resection. If I were to do a colostomy, I typically do as distal as possible, because a lot of times when you bring up a colostomy, you could potentially injure the marginal artery, and that could complicate a future coloanal anastomosis. So I try to go as distal as possible.
And let me ask another question. Do you prefer protective ostomy in every case of that have got the preoperative radiation or not?
Well, generally speaking, if they've had radiation, I'm going to divert them. I think that for like, especially for rectal cancer is the one that would get radiation, and Aaron Grossberg does a lot of our radiation. But I would say that the risk for anastomotic leak is up to 20% if you can palpate the staple coloanal anastomosis with your finger from the anus. So whether it's 5 or 6 or 7 centimeters, it goes from maybe a 5% leak rate to a 20% leak rate. But then that leak rate goes even higher with radiation. So get super nervous. Radiation is super great because it gives great local control. And in many cases, it actually makes the tumor go away. for our total neoadjuvant therapy, where we don't even have to operate at all. But generally speaking, the surgeons, at least at this institution, will divert any colorectal, whether it's high or low, anastomosis if it's been radiated.
Thank you clearly. Thank you very much.
Thank you ค่ะ คุณปริยานุช anything from you คุณปริยานุช can you hear me any question okay can I move to RPH คุณสุภาคะ any question from you regarding the ostomy care your voice sound staggering can you repeat again เสียงมันขาดหาย
Dr. Vanyapra, sorry, because of right now we have the problem with the internet, and right now we use the internet from Thailand to Singapore and then send to Thailand. So sorry, and for this morning I have not any question.
Okay, later part of your talk, your voice is clear, so okay. Okay, I have one silly question from the patient perspective. Nowadays, I still see the same appearance of the pouch of the ostomy, which is not beautiful. Is there any newer product in the market that patient can wear and it's more aesthetic look?
Oh, well, they all look pretty similar, but the thing is, some of them have are opaque, so you can't see the contents. Some people like that. Some of the appliances actually have a charcoal filter, so it'll actually let air out, but it'll like absorb a lot of the odor. So it doesn't protrude as much. So patients, it won't be seen by other people. But it doesn't look great, and patients always ask if they can avoid it. So I would say everyone manages it differently. Patients tend to be more hopeful if you can tell them it's temporary. I used to have a 17-year-old kid who had Crohn's disease, who had an ostomy for a fairly long period of time. And he coped with it by going to the local zoo, and he would stand behind a couple holding their hands, and he'd open up their bag so they could smell his ostomy. And then the woman would invariably slap the boy because the smell was behind them. So she just assumed that he farted in a public place. And that gave him great joy and happiness. So whatever helps them cope with having a temporary ostomy.
Very sad. With this kind of thing need to be done. So I hope that there will be some more product in the future that could produce.
So some people
zero
actually
odor.
have cloth coverings that they could put on top of their appliance to make it look like different things, like a cow or an animal or something. So it looks cute. Those tend to work better for our younger patients. But the appliances are not the most attractive.
Yeah, I just hope in the future we have a great product to address both the bad odor and the appearance, and it will create much more confidence for the patients. Thank you. That is my question to you. That's all. And any one final question before we finish, everyone? Sorry that I may not see all of your names here. In case you have some question, just pop up. Okay. Before we finish, since Kun Supa from Cambodia is here, can you tell me and Dr. Lu?
About what, Doctor?
Wait. I hear some voice.
Yes. Is it scary?
Okay. I have a, can we, I think we can stop the recording now, Prof, because we have sensitive question to ask Kun Supha. Can we stop the video record now?